Well, hi, everyone. Thank you so much for joining us today. I'm Megan McGregor, and I'll be kicking off today's workshop. So today is Emergency and First Responders Partnerships, Collaborative Models of Response. Before we get started, I want to take a moment to ensure that everyone in our audience is ready and comfortable with the technical aspects of this webinar. As you'll see, closed captioning is enabled for today's webinar. We also have American Sign Language capabilities enabled in this meeting. You can activate this by clicking the interpretation icon on your Zoom navigation bar. If you need tech support during today's webinar, please send a chat to the hosts and they will address that for you. Lastly, if you have questions during the presentation, please enter them into the Q&A area. Those questions will be sent to the presenters and we'll make sure to address as many as we can after our presentation. Next slide. I'd like to note that the views expressed in written conference materials or publications and by speakers and moderators do not necessarily reflect the overall policies of the U.S. Department of Health and Human Services and SAMHSA, nor does the mention of trade names, commercial practices, or organizations imply endorsements by the U.S. government. Today's webinar is hosted by SAMHSA's 988 Crisis Systems Response TTAC. SAMHSA has selected Altarum to provide training and technical assistance to support states, territories, tribal organizations, and community partners across the 988 Suicide and Crisis Lifeline and Crisis Continuum of Care. Along with our partners, W2 Consulting Corporation and Change Matrix LLC, both of whom have extensive experience with crisis services and technical assistance, the CSR-TTAC was formed to support the continued growth of the 988 Lifeline and build a more robust crisis care system. The goal of our TTAC really is to support a crisis care system that is integrated, sustainable, and aligned with evidence-based and evidence-informed practices. Next slide. The work that we do in the TTAC couldn't be done without the support and contributions from our SAMHSA partners. First, we'd like to recognize Ms. Jill Mays. Jill is the Division Director of Crisis Systems Transformation for the 988 and Behavioral Health Crisis Coordinating Office. Next slide. And Ms. Tiffany Russell. Tiffany is the Chief of Crisis and Justice Initiatives with SAMHSA's 988 and Behavioral Health Crisis Coordinating Office. We want to thank them both for their support in putting together all of the projects through this work stream. Next slide. In addition to our SAMHSA partners, we have a wonderful internal team who makes these workshops possible. So Stephanie B., Chizoba, Jasmine, Stephanie Liu, Manny, myself, and Liz. Big thank you to all of you for all the efforts you put into this work stream to make all of these deliverables possible. All right, so for today's session, we're going to review our learning objectives. We'll gain some background information on collaborative response in the crisis continuum of care. Then we'll have a guest speaker who will share some practical applications of collaborative responses. And then, of course, we'll have time at the end for a Q&A. Next slide. For our learning objectives, by the end of this workshop, participants will be able to describe key components of collaborative response models and emerging practices, identify improved outcomes associated with collaborative response models in crisis care, and apply strategies to overcome common challenges in adopting collaborative response models. Next slide. So through this workshop series, we're centering on our discussions on the 3 pillars of crisis care. In January, the first workshop looked at collaborative response within our first pillar, someone to contact. And today's workshop will focus on the second pillar of care. Slide. There we go. I'll be highlighting the someone to respond. Next slide. I do want to point out, just as we did in our last workshop, we'll be referring to responses between first responders and our crisis workforce as collaborative response. And there are multiple models of collaborative response that exist. Their ultimate goal being to provide the most appropriate response based on the needs of the help seeker and the available and accessible resources in their community. So here are some examples of models that exist. So first is our co-responder team. This is often what people think of when we discuss a collaborative response. This is a law enforcement response that includes a clinician. This model is one of the longer standing models and has been shown to reduce arrests, reduce emergency department use, and increase access to care. Next, we have our mobile crisis teams. So this is a behavioral health-led response, either independently or with emergency medical services or EMS. In this collaborative response, calls get diverted to mobile crisis teams so they can address them. They tend to have a high success rate in de-escalating these crises on site. They can reduce emergency department utilization, and they really emphasize warm handoffs and continuity of care. Then we have crisis intervention teams, or CIT. This model is, again, law enforcement led, but CIT provides specialized training to law enforcement to appropriately engage with individuals in crisis and facilitate referral pathways to clinicians and other appropriate providers. CIT usually involves partnerships with the behavioral health agency to aid in the training and to be used as referral sites. CIT increases officer confidence in de-escalation, reduces the use of force in behavioral health crises incidents, and improves diversion to community resources. And then finally, we have community responder programs. These are behavioral health professionals that respond to low acuity crisis calls. They may or may not be supported by EMS, but these community responder teams often employ peers in their crisis response, which has been shown to improve trust in community agencies, reduce arrests, and reduce reliance on law enforcement to handle crisis-related calls. Go to the next slide. So that's not an exhaustive list of the models that exist, but it does give you some ideas of what's beginning to emerge in collaborative response. All of these are based off best practices. So let's look at some of the best practices that support these models. The first is strong cross-system partnerships. Models seek to remove silos, establish formal agreements between first responders and behavioral health providers. This allows for cross-training opportunities to share in de-escalation techniques and emphasizes the need for trauma-informed, culturally appropriate care. They're integrated with the care continuum. Collaborative models must coordinate with 988 and other local services to ensure they're providing supports to help seekers within all three pillars of care. This means they're addressing follow-up and warm handoffs to support continued engagement and continuity of care. They're flexible models. So as you saw, there are many models of collaborative response that exist, and they need to meet the needs of the community and its help seekers based on the appropriate and accessible community resources available. This could look like ride-along teams, on-call clinicians that could respond, and follow-up teams to provide support for crisis after the crisis has resolved. Again, it's about meeting the needs that present. And then finally, we want to focus on data collection and evaluation. We can't determine what's best practice without the metrics to support that. So these models all collect data on metrics, including arrest diversions, repeat crisis calls, and engagement with services. This data can help us to refine our protocols through continuous quality improvement. So let's look at some of the key outcomes that we might be collecting data on. Next slide. All right. So if you're considering implementing collaborative response or you're in the process of implementing, you might be thinking, what outcomes are supporting these models? Data talks, we know that. So let's look at the outcomes in these 5 areas. We have public safety and first responders, emergency department utilization, linkage to care, and suicide risk, and finally, cost and performance. Next slide. So first, our public safety and first responder outcomes. Collaborative response models shift the focus from crisis interaction from criminalization to stabilization. So this allows for a reduction in arrest rates, reduced reliance on punitive responses, shorter call resolution times, increased officer confidence in de-escalating behavioral health crises, and the improved perception of safety for all parties involved. Collaborative response allows public safety to be available for the emergency calls that truly require their attention and give them the skills and strategies to address behavioral health crises if they are the ones responding. Next slide. Emergency department utilization. Collaborative response teams are more likely to de-escalate crises on scene or divert to more appropriate community-based services. This reduces our reliance on emergency departments for behavioral health crises and reduces repeat usage of emergency departments for crisis care. It allows us to utilize the most appropriate and accessible community resources, freeing up emergency department beds for individuals who could not receive care in other locations. All right, linkage to care. So just because a crisis is de-escalated doesn't mean the need for continued care doesn't exist. In collaborative response models, we allow for rapport building through de-escalation processes, real-time referrals based on the acute needs, and on-site safety planning to improve our outcomes. This support leads to higher engagement despite care transitions and increased attendance at follow-up or follow-on appointments. We have suicide risk outcomes. Collaborative response models are a critical access point and engagement mechanism within our suicide prevention system. The rapport building and on-site support that collaborative response provides can reduce repeat suicide attempts by half within 6 months of the crisis encounter. Collaborative response models emphasize that warm handoff and the continuity of care. We know that these two concepts are associated with lower suicide attempt rates across all of our health systems. Reducing risk and strengthening connectedness is what provides us with those outcomes. Next slide. So for better or worse, cost and performance outcomes remain a key metric in implementing collaborative response. We know that there are initial costs to implementing collaborative response. The systems need to be integrated, staff may need to be brought in, training and cross-training may need to occur, but collaborative response models show promise in cost avoidance and system efficiency, and efficiency saves money. Collaborative response saves money from reduced emergency department utilization, involuntary holds, and fewer punitive sanctions requiring jail utilization. The cost saved here can offset those initial costs that exist. Collaborative response models show better performance metrics across the continuum of care when we compare them to siloed programs. Because collaborative response programs often share data, it can be easy to gather data to analyze. Next slide. So that's a lot of slides and information to say something that's relatively simple, which is collaborative follow-up oriented responses save lives. They reduce system strain. This means that we're able to get the right people where they need to be when help is needed. Next slide. So in just a minute, we're going to have a presentation by John Ehrenfeld. But as you might imagine, first responders often can't be where they need to be exactly on time. So we're going to give him just a few minutes to join our Zoom room. But in the meantime, I would love to hear in the chat what collaborative models you might be utilizing in your communities, what ones you're exploring, ones that are showing promise. Please feel free to drop that in the chat so we can take a look at what is being utilized right now. And I do want to call your attention to the chat. John Clay is looking to connect with others, so please reach out to him with a message if they're working in 988 and 911 interoperability. Anne Arundel County Mobile Crisis Team is amazing. They are, and we're looking forward to partnering with them in the upcoming months to hear more about that. We have a community paramedic program in one of the small counties, looking to expand it to other rural communities. Collaborative, MET, and CIT. We have co-deployment models based on dispatch acuity with mobile teams and law enforcement. We have, let's see, a lot of peer supports joining us today. That's wonderful to see. Mental health liaisons working with law enforcement, community violence intervention programs, looking into field mediation programs. That's wonderful. Mobile clinics, mobile clinicians, cross-trained counselors. Virginia has all of the above and would love to see more embedded clinicians in 911 centers. We have community liaisons for crisis centers. In Syracuse, New York, they have trained mental health specialists at our 911 call center that take 911 calls that are mental health related, and they have people there 24/7 now. It's wonderful to see that you have call centers that can support behavioral health crises. Ooh, we still have comments coming in. You guys are super active today. Diversion from 911 to 988 and mobile response. I do want to make a plug while we're talking about that SAMHSA's released a 911 988 risk and liability toolkit to support organizations who might be looking at that interoperability and the potential risk that may or may not exist in doing that. We have MOUs with 911 call centers, with county mobile crisis teams. Buffalo, New York's been running mobile crisis teams since 1980. They have co-responder models that began a few years ago with some police jurisdictions. We also help oversee the CIT training and have CIT teams as well. Peer co-location and looking to expand that. That's wonderful. So now that we know that you have a lot of different models in place, we just talked about those data and outcomes. I'd love for you to share with us what some of those data points or outcomes you've been tracking are that might be supportive for others who are looking to implement and need some of that background information. So again, feel free to drop in the chat. What data and outcome pieces are we looking at? I know we shared those 5 potential data points that might be collected, but it'd be interesting to hear what data points y'all are collecting out in the field. Identifying our high risk and special populations. Absolutely. Collaborative responses need to be supportive of the unique needs of their community and their community makeup. So being able to identify who your community is and what supports might work best for them. Wonderful. Wisconsin has a 988 data dashboard that they just shared. Thank you so much. Tracking the utilization of 911 calls by frequent callers. Number of students and youth who are familiar with 988. MET outcomes, MET survey. Michelle, would you mind coming off mute for a second just to tell us what MET is? I don't know if our comms team can do that for us. I might have just asked for something that isn't this. Oh, mobile evaluation team. Thank you, whoever put that in the
Here
chat.
it goes. Yeah, mobile evaluation team is what MET is. So,
Thank you so much.
I don't
I've
know how
never
to turn
heard.
it off. Oh,
I'm asking our comms team to do things that they weren't prepared for. Thank you all for indulging me there. See, we have people tracking diversion calls for service and saw a decrease of 70% by having mobile crisis in the community. Able to connect callers directly with supports, decrease in high utilizers due to cross coordination. That's wonderful to hear. Thank you all so much for participating. I really enjoyed hearing all of the great things that you're doing and also those data points because those are really so key for us to be able to sustain our efforts. So now I'd like to turn to our special presentation. Next slide. So today we're joined by John Ehrenfeld, who is the program manager for the Seattle Fire Department's Mobile Integrated Health Program. John is trained as a firefighter, I believe. He also has specific training within program management, disaster preparedness, and holds a master's degree in international relations, which is probably super helpful for the work he's done here and abroad. John, we're so lucky to have you today. Welcome.
Great. Thank you so much for having me. I really appreciate it. Okay. Well, I'm going to kick off, and I'm actually going to start with a brief apology. I had a cold last week, and I have kind of that post-viral cough that I have not been able to shake. So if you hear me coughing, I apologize in advance, but it is whatever is going around. So yes, thank you to Megan for the introduction. I really appreciate it. Yeah, my name is John Ehrenfeld, and I'm the program manager for the Mobile Integrated Health Program here at Seattle Fire Department. And I'm going to talk really today kind of focusing on sort of the collaborative nature of what we do within the larger context of crisis response. Next slide, please. So we have in the fire department a sort of a twofold mission. I think this is probably going to be true of a lot of teams out there that sort of have a collaborative model. We sort of have an internal and an external mission. The internal one is serving our operations folks within the Seattle Fire Department. So our sort of explicit goal is to help them relieve the stress placed on them by, high utilizers or crisis calls or situations that they can't resolve. And then we have an external goal as well, which is to serve the people in our community. And so those generally align. There are times where there's not perfect alignment, but in general, most of the runs that we're going to go on are going to serve both of those functions. Next slide, please. So very, very briefly, we've been doing this for a little while now. And so, kind of what I would call out is that our the program, our mobile integrated health program, has been around for about 10 years now, starting in 2016. But the partnership, kind of the collaboration that really underpins the entirety of our program goes back quite a bit further with that. And that is our partnership with the Human Services Department, which is, it's kind of two things in Seattle. It's the Seattle Human Services Department, obviously, as the name implies, but it is also the federally designated AAA, the Area Agency on Aging for all of King County. And this is really important to us because the AAA, as the federally designated entity for King County, has access to all of Washington state level record systems, claims databases, benefits databases, long-term care databases. So this is all something that you could not get through the fire department, and so this partnership kind of opens that up. So we've been sort of steadily growing and iterating in our program for quite some time now. Next slide, please. So yeah, as I mentioned, I want to talk a little bit about sort of the partnerships that have made this program possible, and that have allowed us to kind of really been able to build a sort of a crisis response program along the parameters that we set. So, for anyone who's looking at sort of a more, a first responder based model, whether that's law enforcement or fire, to me, almost everything starts with our executive sponsor in the fire chief. Now, obviously, I think any fire EMS-based program obviously is going to roll up to the chief. That's how these programs work. But I think the really important distinction here for us is that the chief has, kind of in the parlance that you use, has drunk the Kool-Aid. He has been sort of a champion for our program. He leads with the program when he's talking about the operations that SFD does. He puts fire suppression, EMS, and mobile integrated health or crisis response on equal footings. We are not sort of the second player. We are not sort of the redheaded stepchild, as it were. We are put on an equal level with the other parts of co-response or first response. And I think he's been very consistent in that, and that has really sold counterparts at whether it's city council, at the county level, at the state level. on the importance of this work. And so kind of having that champion has been really mission critical for us. I mentioned again our partnership with the Human Services Department. That really underpins everything we do, and we now have a very productive relationship with Harborview. For those of you who are not from the Seattle area, Harborview Hospital is the large public safety net hospital for the Seattle area, and actually for even states adjoining Washington State. So yeah, they are the hospital of last resort for really anyone in the greater region. We have a steering committee where we've really tried to pull from kind of our internal departments and the fire department, and then a lot of our external partners, whether it's law enforcement, our dispatch program, human services, and then rank and file, to really kind of help us build sort of a collaborative model. Now, I think kind of depending on what state you are in, kind of the role and the input of organized labor is going to look a little bit different, depending on the nature of the state. But in Washington, Washington is a very strong labor state. But with that said, it was absolutely kind of critical for us to have and attract the cooperation of the labor unions and the bargaining units early on in the process. And we have heard anecdotally of either fire department based crisis teams or sort of community based crisis teams that have gotten into sort of almost immediate confrontation with the bargaining units about really it usually comes down to scope of work. And we were very lucky, IAFF Local 27, which is the firefighters union here at SFD, basically from day one, they said, you're using firefighters on your units. This is our body of work. You're obviously solving a problem that needs to be solved. We're going to support you. And so it's been a really collaborative relationship. And so I think for us, it's hard for me to sort of overstress the importance of building that collaborative relationship up front. And then, the other labor union, Local 17, mostly represents the civilian professionals in Seattle, and that as a civilian labor unit is much less used to sort of the response based work that we're doing, and so we've had to bring them to the table and say, hey, this is why a case manager who's going on our lights and sirens on our overdose unit, this is how their day is going to look a little bit different from, say, like a receptionist or sort of a clerical staff member, and we've just kind of helped them understand what that looks like, and then in turn they can advocate for us. And then we've also had a really good cooperative relationship with our medical direction here at SFD, and that allows us to do things like alternative transport. So we can basically take any person who is medically stable and transport them to any location that we think is clinically or socially appropriate. And that's huge for us because there's a lot of programs out there that have basically said, well, we have a lot of restrictions from the top. You have to go through the protocol, or we can only take this type of client to this sort of location. In contrast, our medical director basically said, take them wherever you want, just make sure they're medically stable, and we will trust your judgment. And that has been really sort of a game changer for us. Next slide, please. Um, the 988 team asked us to look at kind of some of our processes and what we do for information sharing. We rely a lot on what we call coordination of care, continuity of care. And because we are responding to sort of more time sensitive things, not necessarily on the initial EMS call, but pretty soon after that, we interpret that fairly broadly, and so we are able to share a lot of information without a ton of without a ton of hoops to jump through, which is obviously really critical for us getting, we get, doctors on board and case managers and social workers, other advocacy groups, and that's really important for us. There are obviously specific exemptions for things like substance use disorder under 42 CFR, but broadly speaking, we can really push coordination of care pretty heavily on our work, and I would say that we're very reliant on that. SFD has just entered the billing business, which means that we are now a covered entity under HIPAA. We now need to pay attention to HIPAA in a way that we didn't used to, because we used to formally not bill for any service. And yeah, now it's just a matter of providing kind of basic education to our team about sort of what is PHI, what are the allowable sharing elements. We have a couple shared ROIs which help us a lot. In particular, in Seattle, we have sort of two high utilizer groups that obviously have a lot of overlap with our clientele. We are baked into their release of information, which is really important. And then we also, as I mentioned, had that relationship with Harborview. This gives us access to Epic. So for those of you who aren't Familiar Epic is sort of the main emergency or patient medical record system used by healthcare in the United States. We have full access to the hospital's Epic records. We can even write in them, which is huge for coordination of care. So we see someone on the street, we can now pull up their medical record. We can get their diagnoses. We can see who's on their care team. This was an absolute game changer for us to get this access, and we were able to parlay that because we are under the fire department umbrella and are a healthcare entity ourselves. Right now, I should mention as well that we're working with Public Health, which is a King County-wide entity, to set up basically a data sharing platform specifically for folks who are looking for medications for opioid use disorder, and that is going to allow us to do a lot more coordination on that front. So, I think within the boundaries of sort of what's legally permissible, every kind of new database or access that we have gotten over the years, I think has only increased our ability to sort of, I think, drive good outcomes for our clients. Next slide, please. So just some of the nuts and bolts stuff about what our team looks like and how we do it. Again, everything that we do is sort of based on this co-responder relationship, which means a combination of uniformed staff, which are firefighter EMTs, and then our case managers into the human services department. So most of our rigs look like 2 firefighters and an EMT. We can drop down to just 1 firefighter, and they can provide most of the same interventions. We also have a large pool of firefighters who are trained in our program. And I think for fire EMS-based operations, this is really important, because what that means is that on a given day, I'll probably only have about 7 firefighters working on my team staffing our units, but the rest of them are now back out in operations. They're on their fire trucks and ladder trucks, and they have all the specialized training and education that we provide them. And so it's really sort of a force extenders, I would say. It really helps them bring this specialized knowledge of, crisis intervention and de-escalation and referrals. They bring that back to their companies when they're not working on our units. So we have a number of centrally deployed teams, and we've been slowly working on adding more as time goes by. Next slide, please. So we cover the whole city of Seattle, which again is a huge advantage to being fire department based. We can go anywhere that we want to, side of the road, apartment, house, doesn't matter. We have, really, really good access. And, one thing that we say all the time is that the fire department gets us in the door. So we deal with a lot of clients who are sort of in, I would say maybe like sustained crisis, maybe an older individual, very distrustful, of, let's say, adult protective services, case managers, social workers. You get a firefighter on the door, and like people recognize that patch, they recognize that uniform. Not only are they opening the door now, they are inviting them in and showing them pictures of their grandchildren and asking them if they want a cup of tea. So fire EMS really, really opens the door for us in a huge way. We operate 7 days a week till about 7 p.m. And what we always say is we are well aware that crisis does not stop at 7 p.m. That's just what our funding permits. So we have to it's a balance between when our folks can work, when we have funding for. I think in an ideal world, I would like to go, at the minimum till 9 or 10 p.m. Just looking at kind of, when we see the preponderance of calls, but, we're not budgeted for that right now. We have EMS equipment on all of our rigs, which we can use as needed. We have a wheelchair van, really, really important, I think, in urban areas, lots of folks with mobility impairments. And then as far as how we get in front of our clients, we can be directly dispatched by 911, and that's primarily for crisis and suicidality. Just the way our team is composed, we have historically de-emphasized that method, and that's just because our team works best when we get a really good eyes-on referral from a firefighter in the field. When they look at a client and they say, I see what's going on here. It looks like you're a good fit for Health One. I'm going to call them. As you know, and 988 is a different beast, and 988 I think has the time and the capacity to really, I think, do very nuanced sort of intakes. 911 doesn't, right? 911 is constantly up against the clock. They have, somewhere between 30 and 60 seconds to process these calls, and they just do not have enough time to really, I think, develop a full picture. So we have found from the co-response element, it typically makes more sense to send EMS first, and then EMS can get on the radio and say, hey, can you guys come and respond? So that is much more common for us. And then we do a lot of self-dispatch, and that'll be either, we read a referral that came in overnight and we go just drive to the person's house, or we jump a lot of calls primarily for overdoses. Next slide, please. So one of the things that we always say that we have in the toolbox that first responders don't, and I think this is going to be really broadly true of most kind of crisis response elements, is we have time. Right. So fire EMS units are constantly looking at the clock. They just don't have the time to spend to really, really dig in on crisis. We do. And that is one of the things that we say that this is one of the main reason why you should call us. You as, engine 6, you can't spend an hour with this person really diving into it. We can. Perfect example, last week we got a referral from a partner agency. It was an older adult, terminal cancer diagnosis and very acutely suicidal. They spent about 4 hours in this guy's house, and were ultimately able to get him, where he needed to go. A frontline first responder unit just can't do that. They don't have those 4 hours to spend. They have to clear and get back in service, but we do. I mentioned the alternative transport destinations. Again, we can take people to crisis centers. We can take people to, inpatient service if that's what they want. We could take them to, the pharmacy. And then we really have a strong emphasis on ED diversion, on keeping people out of the ED if they don't need to be there medically, and then on doing more handoffs, on physically passing them off to another provider or team in the field. And again, we've been pretty successful at this. Last year we sent more people to alternative sites that we saw in the field than we sent to an emergency department. Next slide, please. So, for us, we are not only a response service. We are also a case management service, and that is really the kind of what we always say is that's the secret sauce, right? The people that we're seeing are very, very complicated. They have overlapping behavioral, social, and medical needs. That, are very hard to disentangle from from a single visit. Let's say we're dealing with someone who is experiencing unsheltered homelessness. You know, sure, we can get them into shelter for the night, and we do that a lot. But let's say we want to move them into housing. I mean, that takes, weeks, sometimes months of very, very intense follow-up, lots of referrals, lots of meetings. So this is why we are also a case management service, because it's client centered. It allows us to build sort of a longitudinal relationship with people. Over the years. So we have a core case management service. We also do complex case management for sort of proverbially the highest fruit on the tree, the folks who are sort of in the most acute crisis over time. And we've seen really, really good results from this. From this strategy, the majority of the people who are enrolled into our service, if you measure after as opposed to before their enrollment, do see a pretty substantial reduction in their 911 utilization. Next slide, please. So, we have what I would say is, one of the benefits of being embedded in the 911 system is that, we're low barrier. We can see anyone we want to, essentially. We don't have any built-in rule outs of like, well, clients have to be over the age of 60. They have to be housed. They have to be on, Medicare. They have to be a U.S. citizen. We don't have any of that. The EMS can see anyone in the community. We can see anyone in the community. So we have like a really deliberate focus on, sort of more underserved, under-resourced, at-risk populations. And then I would say using kind of an EMS-based approach, which we do, allows us to contact a lot of what I'm going to call sort of like the invisible or the unseen clients. These are people who they're not outside on the street. They're inside their house, but they're still in crisis inside. And let's say they're having frequent calls, but they're only seen by EMS. We can see a lot of those folks. So yeah, between chronic poverty, behavioral crisis, and substance abuse, and then older adults aging in place. Those are sort of the threads that sort of really unite uh, all of our um, all of our clients. You know, the you know the the other thing I mentioned, the older clients, this is a clientele that is often, has a lot harder time reaching out to resources, understanding options. I still remember in COVID when all these teams started shutting down, we stayed operational and all these other teams and services started shutting down. And a lot of them would say like, oh, okay, well, we have a telehealth app on our, that we can make available. And we're thinking, of our client, like 84 years old living in low income housing, they don't even have a phone, much less a smartphone. Like they're not going to access an app. They're not using a smartphone. They need that in-person response. And I think that that is kind of one of the advantages of teams like this is they can capacitate that, that sort of human physical connection. Next slide, please. I want to talk just a little bit about the overdose program we've started because this is it overlaps so much with sort of like public crisis. And there's so many elements I think that are, that really unite it with, I would say, sort of more traditional behavioral health crisis response. We've been doing this for almost 3 years now. And this was, in response to the huge spike in fentanyl that we saw in Seattle. I think most of the rest of the country saw. So we started with just one team. It's the response unit that you see on screen here. Again, either two firefighters and either a case manager or our nurse practitioner. And they basically respond to overdoses, mostly in the downtown core. They go lights and siren, and their goal is really rapid intervention, rapport building, de-intensification. So these overdose scenes are often really intense, right? You'll have, let's say, 5 firefighters and 4 paramedics and 2 EMTs and 17 bystanders and a bunch of cops and security guards and sheriffs. And people wake up after their Narcan and they're in the fight or flight mode, right? They're really overwhelmed. And so our goal is to like quickly get them out of that environment, get them in the back of our rig and say, hey, you're safe now. Let's just talk. Let's see what you want. Let's see what you need. We've followed the science of this really closely. And right now, the gold standard for opioid use disorder treatment is medications for opioid use disorder, which are primarily buprenorphine and methadone. So we carry buprenorphine just on this rig. We were the first team in the country to start giving it out at the EMT basic level. There are a lot of other paramedic-based programs out there that give buprenorphine, but we give it out at the EMT level very, very successfully. We've had no adverse outcomes. People have a dramatically higher level of engagement after this medication. And I think one thing that's really important, right, and I particularly point this out to jurisdictions that are really struggling with ED overcrowding and ED wait times, we're diverting more than 80% of our overdose survivors away from the ED. So we stabilize them, we make sure they're medically stable, we give them buprenorphine if they're eligible for it, and then we take them to, a shelter or a post overdose treatment center or somewhere else more clinically appropriate. And that it's a win-win, right? It's a win for the hospitals because these folks are never coming through the door, and so they can focus on other medical emergencies. And it's a win for the client because they're not getting good service at the EDs. Overwhelmingly throughout the country, I would say the service that folks are getting after a opioid overdose in an ED is very cursory and is really not linking them with the services or the supports that we need. So this rig rolled on more than 1,000 overdoses in Seattle last year. So they have pretty good numbers behind this. Next slide, please. So going back to the kind of the need for case management is, all right, you run the overdose, you stabilize the person, you give them buprenorphine. What then? Well, you need case management. You need someone who's going to follow up after that moment of crisis. Say, okay, you had an overdose, you survived. Do you want to be connected with an opioid use disorder treatment professional? Do you want to try to get into housing? We are extremely lucky. We now have in Seattle kind of a first of its kind post overdose receiving center. It's called the ORCA Center, Opioid Recovery and Care Access Center, and it is specifically designed to take people instead of the ED who have had an overdose. So now, instead of going to the ED where you get a turkey sandwich and kicked out after 2 hours once you're medically stable, We take them to the Orca Center. They can spend up to 24 hours there. They get meals, they get a shower, they get coffee, they get their first injection of long-acting injectable buprenorphine, and they get connected with ongoing supports. And we've seen really, really dramatic rates of engagement and follow through with opioid treatment through this model. Next slide, please. The other element that we've added kind of to our sort of diversified crisis response is higher level medical professionals. So I have a nurse practitioner on our team right now, and she can do all sorts of very cool stuff kind of in that crisis milieu. So one thing is she carries oral antipsychotic drugs. So for people who are medically appropriate and agree to, she can give them a one-time dose of olanzapine for acute behavioral crisis, which is dramatic. I mean, I wasn't on the run, but I heard of one. It was a gentleman in a downtown area who was on the street, writhing around, only partially dressed. We had law enforcement on the way. We get called for it, and we show up, and Jess is able to establish enough rapport with this gentleman to get a dose of olanzapine on board. 30 minutes later, he's sitting in the back of our rig. He's having a normal conversation. He's dressed. He's in fact offering to take our crew out for coffee. And contrast that, I would say, with the counterfactuals. Let's say we weren't there. Almost certainly this guy would have been involved, right? The cops would have come. They would have handcuffed him to a gurney, and he would have been taken up to the hospital. So it's a really powerful tool in that respect. And then she can do a lot of other sort of longitudinal coordination of care. She can write prescriptions. She can write referrals for hospital services. And we are trying to expand this body of work because we've seen, I think, kind of firsthand some of the really good outcomes there. Next slide, please. So the program is growing. We're trying to. I think, like most of these programs, the number of people out in the community in crisis is obviously much greater than our ability to respond to. We're trying to add just more of everything. But one of the things I think that we have been able to do over the years is think strategically, not just about like what's our need, right? Because our need is always fairly obvious, right? I want more case managers, I want more firefighters, I want more vehicles. Like we just want more of our stuff, which is great. But I think it's really important for us to think about sort of like what I'm going to call the ecosystem of care, and to advocate for our partners in the community. And that is, supportive housing and low-income housing, right? That is upstream of so many of the crises that we see, is just the lack of affordable housing in the community. Crisis options, right? Response teams are great, but if you don't have anywhere to take them to, you are really, really hamstrung. So we've really tried to advocate for, yes, build that crisis center in our community. Please do not listen to the NIMBYs. We need this crisis center. It is not only is it not going to be bad for the community, it's going to be good because these folks will now be inside and off the street as opposed to outside in public crisis. Please build this center. We desperately need it. Please build more, shelter and, tiny homes and post-crisis stabilization beds. So we really try to think sort of, broadly of sort of what is our purview for advocacy. And that's where I think it helps being a fire department based program, and that the fire chief's voice carries a fair amount of weight. I'm just the program manager. My voice doesn't carry much, but when I say, hey chief, it would be great if you could advocate in city council for, citing this new crisis center in a central location, that goes a lot further. And so we've tried to use that strategically. Kind of at the high level as well, I should note again, just sort of bringing it back in closing to the 988 system. We've got a pretty robust one here in Seattle, King County. We have a number of sort of privately operated, sort of nonprofit or healthcare system-based mobile crisis teams that take direct dispatch from 988. We are looking as a city into further improving that relationship. And what I really see on the horizon, ideally, is shrinking the gap between 911 and 988 and really making it as seamless as possible for our 911 operators and our 911 center to say, hey, you know what? It sounds like you'd be better served by being passed over to 988. We can do that to an extent, but I really think that we could be doing it with greater volumes and with a lot more nuance for these folks, because so often, what they need is not a fire engine with 4 firefighters. They need that sort of, wraparound service that the 988 can provide. And so I think that is sort of really the next front for us is sort of a single ecosystem of crisis response. So I think that's all the slides that I have, and I can look in the chat. And I don't know, back to you, Megan, if there's any questions from you and the team.